from Nijmegen in the Netherlands will discuss how to modulate high respiratory drive. Thank you, Leo, please.
Good morning, everyone. Thank you very much, Domenico. How to modulate respiratory drive. So these are my disclosures. I don't think anything related directly to this presentation. And first to start, what is respiratory drive? As explained by the previous speakers, it's the neural output of the respiratory centers. And right here you see a schematic of the brainstem. And the brainstem contains the respiratory centers, and the activity of the respiratory centers depends on feedback from the body. Let me get into a little bit more detail. I know it's Friday morning, but still I want to go a little bit deeper into the physiology because I think it's exciting and I'm going to show you it's important. So right here is a schematic of the brainstem. So there's a couple of centers that are really important. Right here, the pre-Butzinger complex. That's an area in the brainstem that contains interneurons that generate the rhythm of inspiration. So these centers generate respiratory drive, and these are tightly connected to this ventral paraphageal region that is connected to the cerebral spinal fluid. So this area contains H+ receptors. So if H+ increases in your cerebral spinal fluid or pH decreases, there's more activity of these receptors and more activity in the pre-Butzinger complex, more respiratory drive. And we could talk for hours about this specific picture, and if you're really interested, I can highly recommend you to read these two papers, but it is important. So, the first feedback from the body to the respiratory centers is chemical feedback. As you're sitting here in this room, the reason why you have respiratory drive is arterial CO2 or arterial pH. Again, I'm not aware of any CO2 receptor in the body. It's all regulated by H+. But a little bit increase in arterial CO2 has a tremendous effect on minute ventilation. What about PaO2? Is that a determinant of respiratory drive? Well, not so much. As you can see right here, arterial PO2, minute ventilation. Arterial PO2 can decrease from 120, 180, little bit of effect on minute ventilation. Only when arterial PO2 is below 8 kilopascal, 60 millimeters of mercury, there is an effect on minute ventilation. So chemoreception is the first feedback mechanism. The second is cortical feedback. Everyone working in a neuro ICU will recognize that a lot of patients with traumatic brain injury, but also patients with delirium, do have a high respiratory drive. As you're sitting here in this room, the cerebral cortex has an inhibitory effect on the respiratory center. So when there's brain damage, we lose this inhibition and respiratory drive increases. And thirdly, reflex feedback. So there are J receptors, irritant receptors, stretch receptors in the lung, in the chest wall, in other parts of the body. And when these are activated, for instance, by inflammation, by infection, respiratory drive increases. You will recognize that. If you see a patient in the emergency department with a pneumonia, with pulmonary embolism, typically pH is 746, 745. For this reason, activation of irritant receptors in the lung. So to summarize, activity of the respiratory centers, respiratory drive is determined by at least, and this is a simplification, but at least 3 feedback mechanisms. Chemical feedback, cortical feedback, reflex feedback. Respiratory drive should result in respiratory effort, which is really different. That's also explained by the previous speakers. And respiratory effort is determined by activity of the respiratory pump. So why are we discussing this? Why is this important? Well, I think that Alexander has explained as well. In patients with low respiratory drive and effort, they're at risk for respiratory muscle atrophy, poor patient-ventilator interaction, sleep fragmentation. While on the other hand, if respiratory effort is high, this may result in lung injury, maybe diaphragm injury, hemodynamic consequences, and a high respiratory drive is associated with dyspnea and sensation. I'm not going to discuss how to quantify drive and effort. That has been done extensively by the previous speakers. But the important part here is, how do we modulate it? Well, then again, we need to go back to the physiology. Here you see respiratory drive, the three input pathways: cortical, chemoreceptive, mechanical. So changing the cortical stimuli, it's sedation, treatment of delirium agitation. Changing chemoreception, extracorporeal CO2 removal, but also by changing your ventilator settings, and the same thing is for setting your level of PEEP. We're going to discuss that in a little bit more detail. So first is patients on pressure support recovering from pneumonia, ARDS. Pressure support of 12, in this case, tidal volume around 10 ml per milliliter. If we decrease pressure support to 6 centimeters of water, you'll see tidal volume decreases a little bit. But at the same time, electrical activity of the diaphragm, the best estimate, as Alexander explained, of respiratory drive increases. So we can modulate respiratory drive by modulating inspiratory assist. But this is interesting. So what is the effect of PEEP on respiratory drive? Very nice study published in the Blue Journal a couple of years ago. Patients with ARDS, wide range of PF ratios. And what you see right here is the airway pressure. And right here swings in esophageal pressure, which represent inspiratory effort. So what they do here in a representative example, the only thing they change is increase PEEP from 5 to 15. And what you'll notice right here, that the swings in esophageal pressure actually decrease by only changing the level of PEEP. So higher PEEP in this situation decreases respiratory effort. And this is for the whole group. Higher levels of PEEP from 5 to 15, lower changes in esophageal pressure, lower effort. And that decreases tidal volume. So what is the mechanism? How does an increase in PEEP change respiratory drive? That was actually quite confusing, because in some patients increasing PEEP, respiratory drive increased, while in other patients it decreased respiratory drive, as you can see right here. Honestly speaking, if you try it in your own ICU, well, no, at least in my ICU, it is not as consistent as you see here, that increasing PEEP always decreases respiratory effort, but these are the findings of this group. But very interestingly, I think actually published a couple of days ago by Domenico Grigo in Chest, he basically did more or less the same study. People 5, people 15, and this is what I see in my ICU as well. Different level, higher level of PEEP. In some patients, tidal volume increases. In other patients, it decreases. Respiratory effort as changes in esophageal pressure. In some patients with higher PEEP, effort increases. In other patients, it decreases. And this is a quite complicated figure, but I'll get you through. So right here, it shows the change in respiratory compliance with increasing PEEP. So these are the patients with increased compliance and higher level of PEEP. And right here, this means reduced effort at higher PEEP. So if with higher PEEP, compliance increases, effort will go down. And these changes in respiratory compliance exclusively result from the changes in lung compliance. Okay, so let me try to summarize this. So, if we increase PEEP, in some patients respiratory drive decreases. Respiratory effort decreases. My hypothesis is, but it's a little bit challenged by the findings from Domenico, it may be the result of increased lung homogeneity, because I tried to explain you earlier, if there is consolidations in the lung, it activates irritant receptors that increase respiratory drive. While in some patients, increased respiratory drive, higher PEEP, increases respiratory drive, but decreases effort because there is an impaired neuromuscular efficiency. For this reason, this is the diaphragm, right? And you know, for every muscle, there's an optimal length for muscle contraction. If the muscle is overstretched, you can generate less pressure. If the muscle is too short, you can generate less pressure as well. So we have shown in patients in the MRI that increasing the level of PEEP shortens the muscle. So if the muscle becomes shorter with PEEP, the muscle becomes less efficient, you can generate less force. So I think the effect of PEEP on respiratory drive is complex, but I just try it in your ICU. I think it's really surprising findings. But in most patients, a higher PEEP has a variable effect on drive and effort. If there's a reduced breathing effort, this could be due to a lower respiratory drive or due to an impaired neuromuscular efficiency of the muscle. Okay, we can also modulate drive by sedation. Right here, nice study from the group of Paolo Navalesi at different levels of sedation using propofol. Right here, respiratory drive is assessed by electrical activity of the diaphragm. The higher the level of propofol, the lower the electrical activity of the diaphragm. So propofol is an excellent agent to modulate respiratory drive, but not opioids. Sometimes people try to modulate respiratory drive using opioids. So this is from the same group at different levels of remifentanil. As you can see right here, under control conditions, with remifentanil, the respiratory drive, the amplitude does not change. The only thing that changes is the respiratory rate. So nicely shown here, the higher the level of remifentanil, the electrical activity of the diaphragm more or less remains the same. So if you want to modulate drive, you should not use opioids. Same thing here, so it's summarized right here. If you want to modulate respiratory drive, benzodiazepines or propofol are the way to go, but not opioids and also not dexmedetomidine. That has limited effect on the respiratory drive. Of course, you can modulate respiratory drive using extracorporeal CO2 removal, very nicely shown by the group of Tommaso Mauri, changing gas flow during ECMO. You can see the higher the gas flow, lower the tidal volume, lower the pressure generated by the muscles. But I don't think this is very feasible in clinical practice. So to summarize, if your patient has a high respiratory drive, it starts with physiology. Try to understand why respiratory drive is indeed high. And if you understand that, it makes it easier to make a choice for one of these options. We've nicely tried to summarize that in these two papers that have been published in the past few years. And my final slide right here, what I've tried to show you, that respiratory drive depends on chemical, cortical, and reflex feedback to the respiratory centers. If you modulate drive, you can do so by just turning the knobs of the ventilator a little bit, inspiratory assist, maybe the level of PEEP, or if that doesn't work, decide upon your level of sedation, treatment of pain, dyspnea, or delirium. Thank you very much.
Thank you very much, Leo. We have time for questions. Ari.
Leo, quick one. Can you just explain a bit on the partial paralysis, like the actual state, research, and practice on that?
Yeah, so I didn't show that, but if patients do have a high respiratory drive on a pressure support, and if these patients are well sedated, we did a trial a couple of years ago, a pilot trial, and demonstrated that with low dose of neuromuscular blockers, so the partial neuromuscular blockades, you can actually titrate your level of your tidal volume, the pressure developed by the respiratory muscles. But this is still, I mean, this was a pilot study, right? It's not something I would recommend right now. I think it's an excellent concept to deliver lung protective ventilation under pressure support. I mean, you still have the benefits of an assisted mode. The respiratory muscles are active. But the long-term outcome, I don't know. The other problem is I think it needs a high level of sedation because the respiratory drive in these patients will still be very high. So if we believe, and I believe Alexander always, these patients probably have a high dyspnea sensation. So this is something that we are actually working on. I think the concept is really interesting. But we need to take care about how we can modulate the sensation of dyspnea in these patients. Because it would be fantastic if we can wake them up, if the drive is high, give them a little bit of rocuronium or neuromuscular blocker, but keep them awake and modulate the dyspnea sensation.
Leo, I wonder if you could comment briefly on the fact that many people, when they think of respiratory drive, they look at the respiratory rate because it's the easiest thing to measure. But can you comment on the difference?
Yeah, I think these are different entities. Patients can have a high respiratory drive, so a huge amplitude, probably a huge dyspnea sensation, but a low respiratory rate. Again, if you go back into these Nature papers where I started with, there are different centers in the brainstem that regulate the amplitude of drive and different centers that regulate the rhythm of respiration. So I think that you still can have a very high respiratory drive, with the disadvantages of that, and a relatively low respiratory rate. So it doesn't necessarily mean if the respiratory rate is low, that the drive is low.
Or the opposite, right? The Navalese paper, it was a very nice figure where you see the amplitude decreasing, but the rate
increases. That's right. Yeah.
Thank you very much.
Thank you.
Thank you, Leo. So it's my pleasure to invite John Marini, well known to this audience, and going to discuss estimation of the hazardous component of ventilating power.
Thank you, Laurent, and good morning, everybody. My problem here is to sharpen our understanding of what ventilator power is in terms of the damage that it can potentially hold for the injured lung. And as I think we know, from the year 2000 to the current 2024, we went from low tidal volumes to low plateau pressures, to high PEEP open lung approaches, to low driving pressure, to prone positioning. Now we're concentrating on low ventilating power as a component. And we'd like to eventually get to the point where we can talk about the reducing the damaging power and the cumulative injurious strain to the lung, which probably causes ventilator-induced lung injury.
Okay, that's why I started.
Energy is needed to inflate the chest, and it is a pressure volume product. So if we look at constant flow ventilation, therefore the horizontal axis becomes the volume axis, and the airway pressure axis has a flow resistive component A, a driving pressure component B, and a PEEP related component C. A, B, and C together accumulate to the inspiratory energy that's elastic in the energy equation. So energy is volume times the total pressure, which has the component A, which is a flow resistive component, a driving pressure component, the average driving pressure component, which is the integral of flow divided by compliance, and positive end expiratory pressure. Now, if we take energy per cycle and increase the frequency over a minute, we've come to know that as power because it's energy per unit time. But it's a very strange form of power. It's actually just cumulative inflation energy over the period of a minute. It's not really the intensity of the force that's damaging the lung. And I'll try to explain more what I mean about that as I go on. Power is cumulative energy per minute, as I just mentioned. Power, then, is minute ventilation times the average pressure, the mean pressure, and it has the same components as the individual cycle. But the factor here is minute ventilation, which includes not only volume, but of course frequency. The three primary determinants of Villi risk, the mechanical stimulus for Villi, is certainly power, but that's affected by the duration of high power exposure, the frequency of high stress cycles, and I emphasize high stress here, and the damaging energy per cycle, which is conditioned by the vulnerability of the tissue and the amplifiers of the risk to the individual component of the cycle. So I think we all know that principles from the year at least 2020 till now. We're thinking in terms of power and driving pressure and you know the value of prone positioning to try to even out the heterogeneity and the vulnerability of the lung. Where do we go from here? Pressure, volume, and total power are all Villi correlated, but they're imprecise determinants of the cellular strain and hazardous tissue stretch that we are really concerned about. And we have to ask ourselves, could we do a little bit better than just measuring at the airway opening the flows, the volumes, and the pressures? Can we estimate the true risk of Villi just a little bit better? And this is really a conceptual talk. So please don't take it immediately to the bedside, but I want you to think about these questions. When you talk about power, and you tell me that a power level of 17 joules per minute is super dangerous because it's correlated with mortality, to me that makes an impact, but it doesn't make any sense. Until you know the size of the baby lung that you're putting that power into, you don't know the specific power and the stress and strain that's going into the tissue. Unlike pressure, which we can measure, the baby lung concentrates power. And to know that concentration, we must know the FRC of the baby lung, which we don't know and we don't measure at the bedside. That should cause us a little bit of concern. For specific power, now specific power I mean relating to the small baby lung, we need to consider the resting volume or the FRC. The specific power is the measured power, and it's, if you want to make a simple comparison here, if I put an airway pressure of 30 centimeters of water into this large lung, I have a global power of 4 joules per minute. I do the same thing for this baby lung. I have an airway pressure of 30 centimeters of water and a global power of 4 joules per minute. But the specific power that's going into that baby lung is much, much greater. Unmodified energy and power are not enough. Damaging energy also requires a high stress and strain threshold to be crossed. Let's say we have a pressure, this is an alveolar pressure, that's high enough as we raise the volume close to it and get to that point. Any further volume increase and pressure increase delivers an energy, a damaging energy, or potentially damaging energy, that's quite different than what we currently measure as the general power. And you might say, what's the threshold? And that's a good question. What is that threshold pressure that we're concerned about? Well, the different locales in the lung, high and low, will have different thresholds that we have to concern ourselves with. For example, if we're actually at this point high in the lung, where we already have a fairly high pressure, then the threshold pressure that we need to cross is actually quite small. Whereas in the dependent area here, we have actually a fairly high level of additional pressure that we need to apply to get to a threshold. The point here is not the numerics of what I'm talking about, but that different locales in the same lung have different thresholds and vulnerabilities to stretch. That's not talking about the amplifiers of stretch, which occur in the dependent areas, which I don't have time really to talk to about today. Again, let's look at our pressure versus tidal volume relationship here. Volume on the horizontal axis, pressure on the vertical axis. And we're looking at elastic pressures here because this flow resistive pressure is probably not numerically related to the energy that we're worried about. The energy of the total cycle, which goes into the power that we compute, has basically a safe zone and an unsafe zone, depending on whether or not we've crossed the pressure threshold. The pressure threshold varies with the vulnerability to injury. And as in medicine, we tend to say this is a safe pressure, this is not a safe pressure, but we forget that the lung is changing continuously from a fairly vulnerable lung in the early part to a less vulnerable lung in the latter part. And in the latter part, we may have a smaller lung, which has a higher energy, specific energy, but less vulnerable to stress and strain. So it's quite complicated in some ways. Just putting this as an illustration. If I have a threshold pressure that's at this high blue line, and I have 5 cycles, and I have a PEEP component, and I have a driving pressure component, and I do never reach the threshold level, this is relatively safe power. If I'm exercising, I generate many, many joules of energy over the course of a minute, possibly 60s, possibly 100, and I don't damage my lung. But in the setting of ARDS, we may have a threshold pressure that we cross with our elastic pressures, and then we accumulate these damaging pieces of energy. That will give us at a respiratory rate of 16, a damaging level of energy and power. If I reduce the number of cycles, but increase the tidal volume, I still can generate the same level of damaging energy. If I were to keep the same tidal volume as I had before, then I would have less damaging energy produced. Can we estimate how much of the energy per cycle is damaging? And the answer is probably no. But in a paper that we've written, if you're looking at just driving pressure and looking at the hazardous ratio, how much energy above the hazard are we generating above the driving pressure that's dangerous? It's a fairly simple equation. It relates to the threshold pressure, it relates to the plateau pressure, and it relates to the driving pressure. And these are the two simple equations. One if you're concentrating on driving pressure, one if you're concentrating on plateau pressure as what you're concerned about. So what is that threshold pressure? I simply don't know, but at the bedside right now, we use 15 centimeters of water for a driving pressure and 30 for a plateau pressure. That's a start. That's just a start. But now here's the important and challenging piece of my talk. The villi action is not inside the alveolus. We can measure pressure, we can measure volume because they communicate via the air channel that leads us to the airway opening. But what are we really concerned about? We're concerned about the cells and vessels at the periphery. And those are subjected to hoop stresses. And those hoop stresses are associated with tension. And what is tension? Tension is force not per unit area, that's pressure, but tension is the ripping force or the force per unit length. And that's at the periphery of the alveolus that we're so concerned about. You've all heard of the law of Laplace, and you know that tension is the product of pressure times radius divided by a coefficient, in this case 2. When I put energy into the alveolus, which we're representing by a sphere, that same energy is distributed on the surface, but in a different way. It's not pressure and volume anymore. It's tension and area change. Tension and area change. They sum to the same amount of energy, but they distribute the ripping forces differently and the straining forces differently. If I take an alveolus that has normal thickness and a normal resting lung volume, and I compress that alveolus to a smaller volume, I have a normal thickness but a reduced volume, I have a bigger thickness, I have a bigger denominator, and the tension is less. If, on the other hand, I take that same alveolus and expand it, I thin the margin, which actually reduces the denominator, I increase the radius, and I increase the pressure, and I increase the tension. I don't know how many of you have seen patients at the end stages of COVID-19, but they have cysts that form. There's a tendency to coalesce individual alveolar units into cystic form because there's more damage and stress and strain occurring in that setting. We can talk more about that later if you so choose. So this is theory. If we consider tension, what does that really imply? It implies that a lower resting gas volume, or FRC, is an important contributor to tissue tensions during tidal volume delivery. If I deliver the same tidal volume with a smaller FRC, I increase the tension at the end of inspiration and cause more damaging tension and pressure. Higher pressures at membrane thinning lead to a tendency to merge alveolar volumes and cause this formation. If we recruit without overdistending, that lowers the membrane tensions and ripping forces. And end-tidal hyperinflation causes mechanical paradox during chest wall loading, as we've talked about earlier in this meeting, and I think most of you know that when you push on the belly, sometimes the plateau pressure goes down because you're overinflated at the end of inspiration. We need an estimate of FRC. Finally, what about that local stress focusing that I mentioned before and that you all know about at the junctions of closed and open lung units? Local stress focusing increases tension and strain. If we have a reluctant left lung unit to expand and surround it with other lung units that are expandable, we generate excess pressures and forces and energy loads at those junctions in a simple spherical model. And in a paper that's just been accepted, we could compute the interface stress multiplier of tension between a low compliance area and a higher compliance area of a similar volume, an interface strain multiplier of area, which relates to strain by a ratio of the relative compliances and exponents to those equations. I don't want to go too deeply into that because it's theoretical, but I think using bedside parameters, we can actually use it. Final slide. Total elastic energy. Okay? And we have frequency. Total elastic energy and frequency, we get the elastic power. This is more or less what we currently use. If we relate it to the size of the baby lung, we have a specific elastic energy. And the specific elastic energy eventually distributes into tension and area change, or incremental surface area change. And when we go down the line here to incremental stress and strain, we could get to the Willi risk per interface. And if we know the interface proportion, which we can estimate in that paper I just mentioned to you, we get the Willi risk per cycle. We multiply that by frequency, and we come much closer to Willi risk. These are conceptual thoughts, but really, we're guaranteeing ourselves pressure and volume and flow, and maybe the action and some of the confusion we have relates to something different, tension and the area and strain shift that's happening at the periphery of the tissue. Thank you.
Thank you very much, John. Maybe one comment, because I like very much your idea of a threshold, right? Below the threshold, you may not see much. I would argue that you need also a lower threshold, because I'm concerned by people saying, well, let's go to lowest PEEP, lowest power, and at very low FRC, the pulmonary vascular resistance are very high, and we need some PEEP to restore some lung volume to protect the right ventricle. So I would say we need a window of values with a low and a high threshold probably.
Yeah, that's absolutely right, Laurent. We need to expand the size of the baby lung so that when we do that, the end inspiratory stretch that we have is less than it would be if we have a smaller baby lung. There are many interesting little pieces to this puzzle that I've just put in front of you, but I believe, quite strongly that the physics will tell us that this is the direction we should go.
Thank you very much.
Thank you very much, John.
Thank you.
So it is my pleasure to introduce our last speaker, who is Konstantin Zuldryski from Poland, who will discuss the role of flow-controlled ventilation as a novel ventilatory modality. Thank you.
Thank you, Domenico, for this very kind introduction. I hope you'll notice that my family name will be the most difficult part of this talk. So, what about flow-controlled ventilation, something completely new? How can it be applied in clinical practice? It doesn't make sense. So these are my disclosures. None of them have anything to do with this topic. We wrote this review paper having little amount of data just to explain the principles of modality. Because if we look at the curves, and especially the flow curves during mechanical ventilation, whatever the mode we use, you can easily notice that the expiratory flow every time looks the same. Why is that so? It is because irrespective of the type of the ventilator we use, and irrespective of the type of the mode that you select, you always have the same mechanism, because all you control is the inspiration. So they all act like this internal combustion engine, and they look different, but the principles are exactly the same. This is something different, in fact, because this was the iron lung, and so far that was the only modality, the only technological solution that allowed not only to support inspiration, but also to support expiration. However, as the airway was not controlled in this mode, we could not control the expiratory flow. So what we could do was support expiration, quite unlike in the conventional modes, but we could not control the expiratory flow. So this new modality's novelty is based on completely different principle of expiration. Because what we get is an active and supported expiration. So the expiratory flow looks like this, right? Constant inspiratory flow, constant expiratory flow. And the resultant pressure curve looks like this. Completely different, right? So when you add this flow-controlled ventilation, you see that flow pattern, especially expiratory flow pattern, is completely different. And this is the novelty. Why was it invented? Because some anesthesiologists experienced real trouble while ventilating the patient via very, very narrow airway, very, very narrow tube, which was necessary, for example, for upper airway surgery. Because inspiration, for sure, is simple, because you can perform it quite easily with jet ventilation, can't you? But what about expiration? You cannot control it. What you get is CO2 accumulation, right? So how about we invent something that is based on Venturi's effect that can also support expiration in an active way? And this is what they developed. It was quite simple, but the entire ventilator is based on this principle and on this invention. They have a patent for that, and then they started testing the solution first in surgery, so that in anesthesia. And it proved to be quite useful in various applications, right? Okay, there are also some observational studies. This is only for anesthesia. What is interesting in these animal studies is that you can get very good gas exchange, very good CO2 clearance, and very good oxygenation with a lower minute ventilation. Look at the upper graph. There you have minute ventilation, and you have better gas exchange with less minute ventilation. So that could be useful, especially because when you look at this analysis of the CT scan, you see that you have better aeration and less collapse in the lung. So you have better recruitment in the lung, right? Okay. They also calculated that controlling both inspiratory and expiratory flow can have positive impact on the amount of mechanical power that is delivered in terms of dissipated energy. If you prevent the lung from uncontrolled collapse and uncontrolled expiration, you can probably attenuate the amount of energy delivered, which is quite interesting. Here you can see in another model, also in pigs, in one lung ventilation. Sometimes you have to ventilate one lung in cardiac surgery or thoracic surgery, that you can apply lower mechanical ventilation, lower mechanical power compared to volume-controlled ventilation, and the outcome in terms of gas exchange was similar. Also, they performed some EIT assessment, and it proved that the distribution of ventilation was also better, probably due to equalized emptying of the parts of the lung with different time constant. And this is the last study in animals that was performed and published quite recently in this year in a porcine model of abdominal hypertension, which you can compare to, for example, robotic surgery or laparoscopic surgery, and they noticed again that even in high intra-abdominal pressure, what you get is less collapse and better aerated lung. And they also added this microscopy, and you see that especially on the third graph on your right, you can see that even with high intra-abdominal pressure, the homogeneity of ventilation during flow-controlled ventilation was better compared to pressure-controlled ventilation. So this is really, really interesting. In this part, you can see that the mechanical power was lower despite of and the minute ventilation was also lower with the same amount of gas exchange compared to pressure-controlled ventilation. So, what the inventors tried to prove is that it can be also used in humans. Unfortunately, due to the nature of the method, you cannot use it for assisted ventilation. So it can be used only for patients who are absolutely passive. So the population they picked was moderate ARDS, completely passive patients, not so huge numbers of patients, but you can see that that was feasible. There was no significant difference in terms of oxygenation using flow-controlled ventilation, and the CO2 clearance was also similar, even though minute ventilation was smaller and significantly lower compared to conventional ventilation. There is only one product that provides this. It's produced in the Netherlands, as far as I remember. There are different solutions how to deliver this kind of ventilation into the human. There is a tri-tube, so very small tube designed for upper airway surgery or single lung ventilation, or there is an adapter that you can be used for normal endotracheal tube. This is what the user interface looks like. What you set, in fact, is FiO2 inspiration flow and inspiration to expiration ratio, and also the upper pressure and the lower pressure. These are all the settings that you can apply in this mode of ventilation. We have some experience with that, mainly in surgery, but also in COVID. We tried it in COVID. So this basically, it's interesting and it's quite useful for narrow airway, right, for anesthesiology. It provides surprisingly effective and safe controlled ventilation. Interestingly, it delivers less mechanical power and less dissipated energy compared to conventional modes. Compared to these conventional modes also, the distribution of gases and the distribution of tidal volume within the lung seems to be improved with this modality. But, there are several buts, it's only available in passive patients. Second is, there is absolutely no backup mode. So there is either flow-controlled ventilation or jet ventilation in this machine, and absolutely no backup. It is driven by the pressures that are measured inside the trachea with a special catheter. Once this catheter becomes congested by exudates or whatever, it stops working completely. So you cannot use it unattended. Sometimes also the driving pressures might be high. You cannot leave the patient alone. So you need at least one nurse looking at the patient. So we tried to join this clinical study during COVID days, but it proved to be completely impractical so far. So this is all. Thank you very much.